So good afternoon, everyone. My name is Nafsa Nizam, and I'm the Senior Manager of Research and Guideline Development here at the Registered Nurses Association of Ontario. Thank you so much for joining us today, and I would like to welcome you to this webinar as we introduce to you one of our newest best practice guidelines, a proactive approach to bladder and bowel management in adults, 4th edition, which was published this past winter. So today's webinar will be presented by some of those involved in developing this guideline, including the co-chairs of this guideline, Dr. Jennifer Skelly and Dr. Kathleen Hunter. Dr. Jennifer Skelly is an associate professor at McMaster University and has devoted much of her research in the past 22 years looking at conservative management of urinary incontinence, self-management of urinary incontinence, and best practice guidelines. Dr. Skelly established the Nurse Continence Advisor Certificate Program, and she also founded the Canadian Nurse Continence Advisors Association. Dr. Kathleen Hunter is a professor at the University of Alberta, and her program of research focuses on continence care for older adults, the interplay between continence issues and other geriatric symptoms. While upholding her academic role, Dr. Hunter also practices as a nurse practitioner in a continence clinic. Presenters today also include myself and guideline development methodologist Grishma Jacob and guideline development project coordinator Glennis Gittins. So the objectives of today's webinar is to first and foremost describe the purpose and scope of the guideline, talk a little bit about the guideline development process, highlight a few all guideline recommendations and its practical implications, as well as provide an overview of the RNAO resources to support with implementation of this guideline. So before we get started, we just want to get a sense of who is joining us today and what sector you are from. So you will see a poll pop up in your screen. If you can please indicate what sector you represent, that would be greatly appreciated.
I just want to make sure everyone can see the poll, correct? If you can't, can you just please make a note in the chat?
Thank you. So it looks like we have most people having voted, about 2/3. We'll just wait for the rest. Okay, well, with the people who have voted thus far, it looks like we have a majority of people representing the long-term care and rehabilitation sector, and a good mix of people from primary care, acute care, home care, community care, and complex continuum care. So thank you so much for joining us today, and we do hope that you find the information during this webinar as well as the guideline helpful for the area of practice that you are in. Next slide, please. You'll have to go to the previous slide. Thank you. So who is the RNAO? RNAO is a professional association of registered nurses, nurse practitioners, and nursing students in Ontario, Canada. Since 1925, RNAO has advocated for healthy public policy, promoted excellence in nursing practice, increased nurses' contribution in shaping the healthcare system, and influence decisions that affect nurses and the public that they serve. A signature program of the RNAO is the Best Practice Guidelines Program, which include 3 integrated pillars of guideline development, guideline implementation and sustainability, and guideline monitoring and evaluation. So these pillars really inform one another and work in sync to improve outcomes for persons receiving care, providers, and organization and systems. So the guideline, A Proactive Approach to Bladder and Bowel Management in Adults, has been published this past winter, and you can download the guideline for free on the RNAO website. So if you just click on the free download link, you'll be able to download a PDF of it. And then on the same page, you'll note that there's also some supplementary documents we've included, such as a synthesis of the evidence of this guideline, as well as other information pertaining to our systematic review searches, as well as our guideline search. And if you are familiar with the previous editions of this guideline, so that is the preventing constipation in older adults and promoting prompted voiding, we also included a bit of an analysis or a chart to sort of compare and contrast the two guidelines, so you can really see them side by side of where that information reads in this current edition.
Nathan, it's Jennifer. Can I just interrupt for a second? They're having a terrible time with your volume, and they're sending messages on the chat, but nobody seems to be getting that to you. So I'm going to butt in and say,
thank you, Jennifer. Is it better now?
It's better if you sit right close and speak clearly. That it was going in and out and in and out.
Okay. All right. I will keep at this distance then. Sorry about that, everyone. Thank you for bringing that to my attention, Jennifer. So before we move forward, I would like to acknowledge the entire RNAO team that was involved in bringing this guideline to life, and we have their names outlined on this slide. We would also like to acknowledge the tremendous expertise and guidance of the expert panel of this guideline. So the panel provided critical and valuable oversight and support. The panel included persons with lived experience, and it was interprofessional in composition, comprised of individuals with knowledge and experience in clinical practice, education, and research across a range of health service organizations, academic institutions, practice areas, and sectors. We also had 59 stakeholders review the guideline before publication, and their names are on this slide. Their names can also be found within the guideline itself. I'm going to pass it over to my colleague Grishma to speak a little bit about the guideline purpose and scope.
Thank you, Nathan. So in the next few slides, I'll be going over and providing you with a high-level overview of this guideline's purpose and scope, the main recommendation areas as well, the methodology that we use to develop this guideline. So the purpose of this guideline is to provide evidence-based recommendations for effective strategies to support adults, those who are 18 and older, who live with urinary incontinence, fecal incontinence, and or constipation, that will improve their quality of care and lead to positive outcomes. So primarily, these recommendations are intended for the nurses and other members of the interprofessional team who are in the direct care position, so those who are not necessarily specialists in the continence care. And the recommendations can also be used by educators, administrators, policymakers, researchers, and persons with lived experience. And the BPG can be used across a variety of different settings, including acute care, long-term care, primary care, home and community care, as well as rehabilitation. So there are some topics that are outside of scope for this guideline that we don't cover, and that includes the insertion care of urinary catheters, some pharmaceutical interventions for the prevention and management of urinary incontinence and fecal incontinence, surgical procedures for the management of urinary fecal incontinence and or constipation, as well as any interventions that are targeted at pediatric populations are outside of scope for this guideline. So what are the main recommendation areas that this guideline addresses? So in this guideline, we do have two good practice statements, one that focused on conducting initial assessment on urinary incontinence, and one that focused on conducting initial assessment of fecal incontinence and or constipation. And in addition to the two good practice statements, we also have 5 recommendation areas on toileting strategies, physical activity, interprofessional approach, adequate intake of fiber and or fluids, as well as bowel protocol. So in this slide, I'd like to give you a little bit of information about methodology that we use to develop this guideline, as well as the 3 different strategies that inform our recommendation statements. So the RNAO best practice guidelines, including this one, is developed using the GRADE and GRADE CERT-QUAL methodology. So GRADE stands for the grading of recommendations, assessment, development, and evaluation, and it's used primarily for quantitative studies. And GRADE CERT-QUAL stands for confidence in the evidence of reviews of qualitative research, and it's specifically targeted at qualitative research. So RNAO is implementing GRADE because it's in line with the international guideline development standards. And it's also being used by other large organizations that produce guidelines, including the World Health Organization, as well as the National Institute of Health and Care Excellence, also known as NICE. So based on GRADE, 3 strategies were used to inform the development of recommendation statements within this BPG. And the first one is the use of systematic reviews. So we conducted systematic reviews on the 5 recommendation areas that I noted in the previous slide, including the toileting strategies, the physical activity, interprofessional approach, adequate intake of fiber and or fluids, and bowel protocol. So to conduct the systematic review process, our RNAO BPG team usually work with an external health science librarian. The librarian usually conduct multiple searches on different databases and send us thousands of records to screen. So our BPG team then screened the thousands of records, and we identified the relevant studies for inclusion to support the discussion of evidence. So we also appraised the quality of these final included studies, and we complete an evidence synthesis, and we develop summary documents, which includes the draft recommendation statements. So these summary documents, as well as the draft recommendation statements, are then presented to the expert panel. And the panel then do a vote to agree or disagree, to determine whether they agree or disagree with the recommendation statements, and also to vote on the strength of the recommendations. So that pretty much summarizes the systematic review process. And in addition to doing the systematic reviews, we also developed 2 good practice statements. So I noted the 2 good practice statements in the previous slide. So in GRADE guidelines, a good practice statement refers to a practice that's already accepted as beneficial or practical advice, and a systematic review is not required for the development of good practice statements. When developing the good practice statements, we include GRADE literature as well as peer-reviewed studies to support the discussion of the evidence. And lastly, we adopt or adapt a recommendation, sometimes from high quality or existing high quality guidelines that are based on systematic reviews. And in such case, so adapting means we use a recommendation with modifications, and adopting is we use a recommendation as is. So in such case, the RNA expert panel will need to assess the evidence from the original guideline prior to deciding whether a recommendation should be adapted or adopted. And an example of an adopted recommendation within this guideline is the recommendation on pelvic floor muscle training, or the PFMT. And just to provide a little bit more information about the strength associated with each of the recommendations. So in the guideline, you'll notice that beside each recommendation statement, there is a strength, either strong or conditional. So these are some criteria or considerations that the expert panel uses in determining whether a recommendation is strong versus conditional. So in order for a recommendation to be strong, the benefits would have to outweigh the harms of a practice that is recommended, or harms would need to outweigh the benefits of a practice that is not recommended. Most persons would need to benefit from the recommended practice as well. There need to be a good or high quality evidence. So this really summarizes the methodology and the development process that we use to inform this BPG. And we just wanted to pause and see if you have any questions at all about the content that we covered thus far before moving on to the details of the recommendations. Do you see any? I don't think there's any questions.
So feel free to use the chat box to note any questions, or unmute yourself if you have any questions.
Right. So hearing none, I'll pass it over to Dr. Jennifer Skelly to go over the urinary incontinence recommendations.
Thank you, Grishma. And I just want to check and make sure that my voice tone and level is okay and that you can hear me. Great. Okay.
Yeah, sorry, Grishma, we have one question. Somebody just typed it in. So they just asked if they can go back to the recommendation summary slide, and that's from Judith. Judith McKenna.
Is this the one?
Yep, Judith, do you want to just unmute yourself and? Hi, Judith, can you hear us? If you're unable to speak, you can just type it in the chat. Okay, I don't think she's there, but
She is there, but she's muted.
yeah, I unmuted her. Okay, 1 second.
There we are. Can you hear me?
Yes, we can hear
So
you
that
now.
would be, thank you very much. That would be the slide before this one. I just really wanted to see the other one then. The one before maybe 2 slides before. Remember you have maybe the second one, you have a slide. Oh, this one, there you go. Yeah, so I just wanted to see, so those are the areas where you have brought some changes, is that correct?
Well, I'll answer that question if you like, because in fact, we're going to be covering that now, Judith, as we go through each of the areas. And this whole guideline is different than what our previous guidelines have been. So if you have questions when we're done, then we'd be happy to answer them.
Okay, sounds good. Thank you.
You're welcome. Okay, so I'm going to be looking at the statements, really good practice statements and recommendations related to urinary incontinence. And then Kathleen is going to deal with the bowel and fecal incontinence. And I think it would be good. Can you just move the slide? Because I think we've already covered everything there. That's great. That's perfect. I think it would be worth commenting at this stage that as someone who's actually been involved in the development of these guidelines from the very beginning, 20 years ago. When we first started doing these guidelines, they were related to very specific ways of managing. So the first one was prompted voiding, and then the other one was constipation. This guideline is a great growth in that area, and it was decided that we would look at this as a much more overall encompassing guideline, and it is related to the plan of care for interventions healthcare providers conduct with a focused assessment in collaboration with people who are experiencing incontinence. Next. So in that guideline, there are, okay, actually, I'll just finish what I was going to say on this other one. I should have turned my thank you, sorry. In the practice notes on this guideline, which is on page 36 of the guideline, if you haven't downloaded your copy, please do so. It's very informative. In there, it explains to you how to obtain a proper history from a patient, how to determine the type of urinary incontinence they may be experiencing. There are options for voiding records, post-voiding residuals, and checking for urinary tract infections. All of that information is there. And so that's very comprehensive and a way to help you move way forward. Next. There are also many appendixes. This one in particular, Appendix I, is looking at the conditions that cause urinary incontinence in people. And so it gives you a list of the potential things that could be contributing. Most prominent on that list would be the benign prostatic hypertrophy, which is well known to have an impact on the urethra and the ability to pass urine. But there are other options there, many of which will be important depending on the population of patients that you're dealing with. And then the environmental factors that impact, for example, things we take for granted, such as access to a toilet, and functional impairments as they relate to cognitive and impaired mobility. And then Appendix J lists all the different types of medications at this current point in time. As we know, medications change all the time. And so that, we have to keep updated. And there's a database here for the side effects of different medications that you can get through Health Canada. But this gives us a list of the ones that we need to be aware of that could be contributing to the person's incontinence. Next. So the first recommendation is related to individualized toileting. And this would have been what our previous, where we had prompted voiding. Individualized toileting is individualized toileting is one of the recommendations that the panel rated as quite strong in terms of being an important consideration. It really is something that we often refer to as prompted voiding, but we might also call it bladder retraining. It really is not always able to be done, but it is something that really has to be considered as an option for patients who are potentially able to get up and go to the toilet. And we know that it will reduce incontinence. Next, thanks. This is an example of a voiding record, just to give you an idea of the information that it would be useful to gather when you're trying to make a determination about what might be useful in terms of strategies for management. And this voiding record could be adapted to be used in your own setting, but it clearly identifies over a 24-hour period the amount that was voided, the amount the patient is drinking, and any wet events that may occur. And this gives you a picture of a 24-hour period as to what you may, when things may be happening and when you might want to be able to intervene. Next. And then the prompted voiding protocol is here, and that protocol is also really well outlined in the previous prompted voiding guideline. It is a well-known protocol now. In the days when we first started this in 2000, prompting to void was not something that people took a lot of notice of, but we've demonstrated over the many years that in fact it makes a difference. And if you can get a patient up when they need to void and get them to the bathroom and help them to assist them with the toileting, even if they're mildly cognitive impaired, they can be continent, and it's worth certainly having a trial of that. Next. So then the second recommendation was based on the question about physical activity. And this is different from our previous guidelines because it really relates to the importance of physical activity in terms of maintaining patients' independence and also their ability when living with incontinence to be more likely to be continent. And it's a strong recommendation based on the evidence that's available. It does need to be individualized in terms of activity, but it's not uncommon for patients to, say, for example, be in hospital or be in a care setting where suddenly they are no longer in control of when they can get up and move and do things. And so it's really important that the care providers who are working with them appreciate that they may need assistance and you may just need to ask, and they may be overwhelmed by the surroundings that they're in and may not really know what they should be doing or how they should be doing. And as they get more and more anxious about feeling the need to void, they may not know what to do. And then that's when accidents will happen. And so it's important that we evaluate that. And there are, I think the next slide helps me. No, it's fine. Yeah. There is lots of evidence in the guideline that demonstrates how that's effective for you. And it's part of the assessment process as well. The other new piece was around pelvic muscle therapy, pelvic muscle training, sorry. So I would like to comment about this first, though, that clearly, if you're going to be teaching someone to do pelvic muscle exercises, you need to have some basic education and training on how to do a proper pelvic muscle assessment and how to evaluate their pelvic muscle strength, and then be able to teach the patient how to do the pelvic muscle exercises. There are lots of videotapes on YouTube where people will sit and explain to you as you sit in your chair how to do Kegel exercises or how to do pelvic muscle training. And if in fact you're attuned to your body and you can actually feel your pelvic floor strengthen and relax, then you might be successful. But this exercise primarily is meant for a younger population. It is not something that we're likely going to do a lot of in our frail elderly patients. And I think that just needs to be borne in mind. And given that this guideline ranges the age from 18 to infinity, it's important that we've talked about it. We had a very good physiotherapist who was part of our team who was very helpful with that. It needs to be done for at least 3 months at a time to see if we can make a difference. That would be standard protocol that a nurse continence advisor would be doing. But it does need to be done in conjunction with someone who can help guide the patient properly. There's good, strong evidence to support it. But I'm looking at the makeup of the group who have joined this webinar, and I can see a lot of you come from long-term care. And I think that likely the use of pelvic muscle exercise in that age group is probably going to be quite limited. Prompted voiding is where to go. And then the other recommendation was around an interprofessional approach. And I think this was really excellent because we had on our team, as I think Nathan already indicated, we had quite a good group of people from many different areas, but we had certainly physiotherapists, and we had people who suffer from incontinence, and then we had various groups of people from nursing in different areas where they nursed. We had a pharmacist who was part of that process, all of the bases that you would want to cover to ensure that we're thinking about all the aspects of incontinence and where we should be thinking about using our colleagues to help us. So, you know, for example, when I think about all of the different medications that are out there and all of the interactions that occur with medications, the pharmacist is a key role to know in your facility, or if you know someone in your clinical practice, is someone that you can use as a great resource. And our pharmacist who was on this team was a good friend of mine. I was the one who sort of inveigled her into participating. And when I was in clinical practice, I would often call her or email her and get her advice on different medications. So the interprofessional approach would also obviously include family physicians and specialists, whoever were involved in the care of the patient, urologists, urogynecologists. It's good that we all interact with each other and that we all take time to work together interprofessionally. I came into this process in the 90s when there was only, I can remember going to a meeting where there were urologists and gynecologists sitting at the table. I was the only nurse there. There wasn't even a physiotherapist there. And they were talking about the medication part of it. And essentially we're poo-pooing the idea that nursing would ever have any role to play in continence. And I was pretty outspoken, as I tend to be, especially if I'm getting annoyed with the lack of respect being paid to each of our professional groups. And I spoke up and I said, you know, I think you need to consider that the pie is not divided in half with surgery on one side and medication on the other, because we know, for one thing, the pie doesn't even have a half for surgery. And I think you need to think of it as a pie that's divided into thirds, and that there are rooms for behavioral and conservative interventions that nursing can provide. And as a group, we might be able to bake the pie and get somewhere with it. Next slide. Then at the end of this section, there is a very good algorithm that just kind of leads you through how these things all fit together in terms of the continence statement, and then how do we get to where we are with the different recommendations. And for those of you who are writing policy or who are developing guidelines within your institution or helping nurses to figure out this is really designed for you to be able to see how did we get to where we are. The average person who's caring at the bedside is probably going to look at this and think, what does this mean? But those of you who are in policy, this will be helpful for you for making up the statements that you need and developing the policies that you need. And it really is an excellent way of sort of summarizing what this guideline is about. Next slide. And then finally, there are all kinds of appendices in here related to urinary incontinence that really are designed to help you figure out many different things. There's the algorithm for incontinence care. There's conditions that cause it. We've looked at that, medications, sample voiding record, the validated questionnaire for urinary urgency, if that's appropriate to your population, and then the prompted voiding protocol. So now I'll hand over to my colleague, Kathleen Hunter.
Thanks, Jennifer. So next slide, please. Good. So as for the incontinence section of the guideline, the fecal incontinence and constipation section starts off with a good practice statement. And this really serves to remind us of the importance of always starting with that assessment, focused assessment, and I'm going to add individualized assessment before we put any kind of strategies or interventions in place. And we need to work with the person and our team in terms of selecting and deciding the interventions based on the assessment. Next slide, please. I'm going to go through some of the very useful appendices that are included. And fecal incontinence and constipation are things we deal with a lot as nurses. However, not all of us have really had an opportunity to spend a lot of time understanding well. So these appendices can get us started in that direction. So Appendix N gives us a list of risk factors for fecal incontinence. And similar to the urinary incontinence, these can range for anywhere from medical conditions, environmental conditions or factors, functional impairments. We need to think about that, consider both the cognition and the physical ability of the person that we're working with. And for fecal incontinence, looking at the obstetrical history. Now you might think, I work with older people, and what could the obstetrical history have to do with this? Well, in my clinic, I also work with primarily older people, and there's a lot of really interesting work that's now coming out in terms of women who've had traumatic deliveries, and as a younger woman have been able to compensate because maybe they've had a rectal tear or some other piece or some other event in their deliveries. As a young woman, they could compensate, get to the toilet quickly, but now that they're aging, perhaps getting a bit more frail, the fecal incontinence starts to declare itself. So keep your mind really open in terms of looking at that individual person and what might be happening with them. The Appendix O goes more into conditions that cause constipation. So the other part of this section, and this includes metabolic conditions. Examples are hypothyroidism, which becomes much more common as we age, and diabetes, where we can see diabetic gastroparesis, and that can play a role in constipation. We can see gastrointestinal conditions such as inflammatory bowel disorders, metabolic disorders, and neurological disorders. And some of the key ones here that you are all really familiar with: dementia, Parkinson's, MS, and spinal cord injury. So there can be many things that we need to start to take into consideration and look at that individual person to see what is playing a role. Next slide, please. We have an appendix on medications similar to the one for urinary incontinence with the link at the top. But I do want to talk just a bit more about medications. So one of the medication groups that's included here are anticholinergics. And while we do have drugs that are anticholinergics and we use them in clinical practice for their properties, we need to remember that many drugs that are not listed as anticholinergics actually have anticholinergic side effects. This is one of the most common groups of side effects. And if you can remember, what are those anticholinergic side effects? Think of dry dry, red, hot, mad, and that's dry mouth, flushing, urinary retention, and confusion. So any drug, when you look in your drug resource that lists those as side effects, those are anticholinergic side effects, and they can affect constipation. Appendix Q is the ever useful Bristol stool chart, and I'm sure many of you have seen this before. Some of you might have used it in your practice. And so you can see it gives us types of stool, everywhere from very hard lumps. Some of my patients call these the little rocks, right through into a more formed stool, through to a loose stool. And of course, we all want to be type 3. All right, like a sausage, a few cracks, or a type 4, a sausage very smooth and soft. That's sort of our goal. I find this really helpful in my practice with my patients when I'm getting them to describe what their stool looks like, and we're trying to problem solve together about how we can improve constipation or fecal incontinence. And another way I think that this stool could be very useful in practice is if you're in a long-term care setting and working with PSWs. They're the ones that often are monitoring and assisting the residents to the toilet. And so they could be able to track here what's happening with this person. Is that stool loose? Is it towards the bottom, the type 7? Is it the small little hard rocks that the person is having trouble getting out? So that's important information that we're gathering in terms of our assessment. Next slide, please. This is an appendix I really like. It's our sample bowel elimination record. So often as nurses, we work in areas where we get a charting system provided to us. And sometimes bowel records are just, it's a dichotomy. Did they have a bowel movement or not? Yes or no? But I think this example really shows us the kind of information that we really should be looking at when we're trying to assess a person who's having difficulty with either constipation or fecal incontinence. So it goes beyond that mere check. Did they have a bowel movement or not? There's space to expand on our clinical data, including the frequency of stools, consistency, fiber and fluid intake, whether the person was toileted or whether they had a fecal soiling event. Next slide, please. Good. I'm going to start off on the recommendations now for fecal incontinence and constipation. Our first one pertains again to physical activity, and this is a very strong recommendation for people who are living with constipation. And it's to engage in low intensity physical activity and exercise for 30 to 60 minutes, 3 times a week within their tolerance. And, in a long-term care setting where we have access to recreation and physical therapy aids, perhaps working with the physical therapist and doing programming, we might be able to engage people in physical activity within their limitations. For me, working in a community setting, in an outpatient clinic, this is something I discuss with my patients. Next slide, please. We have recommendations on fiber and fluids stemming from question 5, and we ended up with 3 recommendations here. So the strongest recommendation of these is recommendation 5.2 in the middle. And this is a recommendation around the provision of adequate fluids to people who are experiencing constipation. So important, and we know this as nurses. But how do we get that person to take in, and what kind of strategies can we put in place to trying to make sure that that person is getting a good fluid intake? Recommendation 5.1 on adequate fiber intake to prevent and manage constipation, as well as recommendation 5.3, the optional use of psyllium, are conditional recommendations. So fiber intake, again, conditional, so we may not have the strong studies, but we have a lot of good evidence on fiber, and our dietitian colleagues certainly encourage fiber intake in order to make sure that we're managing our bowels well and preventing constipation. Use of psyllium in 5.3, and now psyllium, and I'm not advocating or endorsing any product, but I'll just mention one product name as an example. You might know it as Metamucil, but there are other products on the market. This can be very useful in people living with fecal incontinence. Again, it's a conditional recommendation, it is hard to get funding to do these kinds of studies, but what psyllium can do in a person who's experiencing fecal incontinence, if they have very loose stools, it helps firm up the stool. It gives shape to the stool. And we all know, we've all had 24-hour gastrointestinal problems. And we know that it's very hard to hold on to a loose stool. So if we can get that stool bulked up and firmed up, oftentimes the person is going to have an easier time holding on to it and getting to the toilet on time. Next slide, please. The interprofessional approach. Similar to urinary incontinence, this pertains to the health service level of an intervention, and it really supports the use of an interprofessional approach in providing care. So Jennifer's identified a number of our important colleagues that can be a part of this. Certainly our pharmacists, our physiotherapists, and I would say here as well, when we're talking about fecal incontinence and constipation, making sure that the dietitian is a part of planning and looking at the kind of approach that could be used in providing care. Next slide, please. Finally, we come to our question 7, which was about whether or not a bowel protocol should be implemented to manage fecal incontinence and constipation. And we've come up with a recommendation around constipation that strongly endorses implementing a bowel protocol. So again, this is much at the organization level. It is development of policy and protocol, but remembering that this is something that does need to be individualized. We shouldn't be developing a protocol that is one size fits all, because human beings aren't one size fits all, and we really need to have that individualized component to it. Next slide. And we have, thanks to the Parkview Manor, who have allowed us to include their sample bowel protocol. This is included in the guideline. And it's just one way of getting started, looking at what they've done, what could be put into a bowel protocol, but again, very focused on the individual and trying to tailor the strategies to the individual person. Next slide. We have the algorithm, and I agree with Jennifer that this is really something I think that the people who are involved in developing protocols and policy, so our clinical nurse specialists, our nurse educators, working with the interprofessional team would find very valuable. And we pulled out, again, the good practice statement, really to emphasize that we should start with assessment. And as for the urinary incontinence, please download the guideline and have a good read through. Look at the practice notes, which are really rich background information in helping you and giving you some guidance in going through that assessment. Next slide. And just an overview, I think we've looked at most of these as we've gone through. I'm just want to say it was just a pleasure to work with the RNAO and be the Western element who came into the guideline, and to work with my colleague Jennifer and our whole team on developing this guideline. We hope you find it's very useful for your practice.
So before we move to talking about some of our implementation resources, we just want to pause and see if you had any questions in regards to the recommendations that Dr. Skelly and Dr. Hunter had presented today. So Kathleen, it looks like there's a question here. I'd like to clarify that a cilium intervention can be useful for loose bowels.
Mm-hmm.
Loose
Yes,
bowel movements.
it can be. Now we have to, again, it's not a blanket statement. Okay, we need to do our assessment, look at what's happening with that patient. If part or that person, if part of what's under consideration is that they have a chronic loose stool pattern. So people, I'll give you an example, people with diabetic gastroparesis, they can have constipation, they can have loose stool, and they can go back and forth between constipation and loose stool. So when they're having loose stool, then that might be a time where we can introduce some cilium to bulk up the stool. If this is a person who is living with something like an inflammatory bowel disease, which can be very difficult to manage, we might want to hold back on that cilium, and we need to be working with a dietitian, and in this case, their gastrointestinal specialist, about how we approach loose stools in someone with a inflammatory bowel disease. But the evidence we looked at for the question provides support that in people who are having fecal incontinence, this is a potential strategy. Again, individual assessment and using our questioning minds to say, is this the right strategy? I'm going to add that we do still use cilium, and you'll see cilium used sometime for constipation. Our question asked that. We didn't find a lot of evidence around that. And I continue to be cautious in the use of cilium for constipation. For constipation, we do want that adequate fiber. We want adequate fluids, but if we can get dietary sources of those, I think that's the way to go. And if you do have someone who is tending to constipation on cilium, making sure that that fluid intake is adequate is so important. I hope that answered your question.
I see that Gina had her hand up, so if you want to.
Hi, Gina. I'm just asking you to unmute and feel free to ask your question. Gina, I see that you're unmuted. Please feel free to ask your question. Gina, I'm not sure if you're having technical difficulties. If you would like, you could also alternatively write your question in the chat box and we'll be happy to answer.
Oh, it is in the chat box. Sorry. It says, do you also suggest the use of meds like Restorelax, like PEG?
Yes, we use a lot of PEG 3350, polyethylene glycol 3350. In our clinic for people who are living with constipation. That was not a question that we pursued for this particular guideline, but from my own clinical practice, PEG 3350 is an osmotic diuretic. Osmotic diuretics tend to be more, I explain them to my patient as they're a gentle way of looking at constipation. What PEG 3350 does is it draws in fluid into the bowel, into the stool. So it makes the stool softer and relieves the constipation and makes that stool easier to pass, because it's much easier to pass a soft stool than it is to pass one that is very hard, and especially those little pebble rocks. Again, the caveat around PEG 3350, adequate fluid intake. So you need to make sure you're doing that balance, and you're talking to your clients and if you're in a long-term care, working with your PSWs to make sure that that person is still getting adequate fluid, because that is pulling osmotically fluid into the stool. So you need the fluid with it.
I also noticed that Barbara Anderson had put a comment in the chat back quite a little while ago about, she raises the question, and it's a good one, that this guideline is based on references the previous editions, the prompt avoiding and constipation, but you can no longer access those through RNAO on their website. I guess she was just asking if we're using it as a preface reference, not being able to access it is somewhat of an issue.
Yes, so because the intention is that this is the next addition to the previous guidelines, so those have been removed from our website, and just working with a panel in this next edition of the guideline, there was some discussion around expanding the scope. So therefore the recommendations do look a little different. And because we have sort of evolved to the grade framework, it really required us to prioritize key recommendation areas by the expert panel. Therefore, perhaps there might be some areas that would not have been captured as recommendations, but in some instances, we tried to capture that information through appendices or practice notes or supporting resources. So we hope that if you have any particular questions about what happened to the information from the previous guideline, we do have a chart outlining the comparison between this edition and the previous edition that can be downloaded as a supplemental document on our website.
So Barbara Anderson raised her hand if she may have further question to ask.
Sure, Barbara. I'm going to unmute you. Oh, we're unable to hear you.
Can you hear me now?
Yep.
Oh, great. Hello, everyone. Congratulations on the guideline. I did a update chapter editing on a bowel elimination chapter. So I drew on the guideline extensively. The struggle that I had is that the guidelines are very different. The new guideline is very different, and there's specific, very helpful material in the previous guidelines that I'd like to still be able to reference or access, and I'm unable to. So I'm just concerned about this being identified as a subsequent addition because it is a very different approach to the guideline.
Barbara, maybe I can connect with you afterwards in regards to referencing the previous guidelines.
I'm not sure that's the point she's trying to make, Nelson, but it may be a discussion that needs to be held afterwards.
Thank you, Barbara. We will take that back in considerations for how we approach next edition guidelines for other guidelines, but I would like to see what I can do to help you accurately reference the information.
Nafs, I've just copied 2 more questions into the chat. The first one is from Jean Clark. Are all changes highlighted to make it easier to see the changes?
So thank you, Jean, for that question. So if this question is in regards to the comparison document, we took a little bit of a different approach in terms of highlighting the changes. In previous guidelines, you would note that, sometimes we had a plus or minus from in terms of how the recommendations change from edition to edition. But for this time around, it's really the commentary changes based on the area of practice from the previous guideline. So it's I hope it is clear, but if you have any questions in regards to how what implications it has for practice, please feel free to contact us.
Thanks, Napson. And we have one more question from Heidi. Are there any guidelines for constipation and the prevention of UTIs?
What a great question. So not that I know of in the prevention of UTIs, although we know that certainly constipation can affect bladder function. We've had a lot of people through our clinic that when we relieve the constipation, we relieve some of the urinary tract symptoms, but I don't know of any work where someone has actually studied whether or not relieving constipation prevents UTIs. Jennifer, have you seen anything?
I haven't, but the only other thing I would add to what you said, am I muted? No. The only thing I would add to what you said is that just good pericare is another good way of preventing it, because what we all know is that as patients, women become elderly, their ability to wipe from front to back is pretty much non-existent. They can't balance to do it. They can't reach to do it. And so they don't know the difference between wiping right through, and consequently the atrophy around their urethra is going to be a big factor in why they get into issues with urinary tract infections. So that's always been the approach, but I haven't seen anybody really deal with it. Yeah. Maybe it's something we should think about.
Maybe we should, and it's we could do a whole 3-hour webinar just on UTIs, I think.
Well, I think prevention of them would be the way to do it. We could combine with someone like Dr. Mark Loeb, who does an excellent one on preventing UTIs. Right. But I think if anybody was going to look at how to prevent UTIs, and it would be something nursing might do, because we have, the knowledge about the personal care things that are really a factor in all of that.
Right.
Thank you for your wonderful questions, everyone, and thank you, Kathleen and Jennifer, for your clinical expertise. So I do note that we have 3 more minutes for this webinar, and if it's okay, I would like to just present some of the RNAO resources to help our participants today with implementation. So now that you have this guideline, what can you do next and how can we help? So we have several ways that we can help facilitate the use of this guideline within your practice settings. So first and foremost, we encourage you to download and read the guideline and discuss it with your colleagues. And you can also take a more structured approach by conducting a gap analysis as an interprofessional group. And this gap analysis will help you really compare your current practice to evidence-based practices in the guideline and help you identify areas that you could potentially incorporate into your setting. You can also become a best practice champion by joining one of our free best practice champion virtual workshops that highlights why evidence-based practice is important and how you can champion best practices in your organization. So these are virtual, they're free, and we do share a certification of participation at the end of the day, declaring you as a champion. And you can also be a part of our national and international group of best practice spotlight organizations. So what this means is that your organization can get into a formal relationship with RNAO to implement guidelines through a designated time period, as well as to be ultimately designated as a best practice champion, best practice spotlight organization. So we would like to also take this opportunity to introduce to you our up and coming Leading Change Toolkit. So this is a free online resource for creating change within health service organizations. So the goals of the Leading Change Toolkit is to promote healthcare excellence at the point of care and to create sustainable evidence-informed cultures. And this toolkit will include 2 complementary frameworks to accelerate success in the uptake and sustainability of knowledge. So this includes the Knowledge to Action framework, which is found in the 2nd edition of our existing toolkit, and then the new Social Movement Action framework. And this toolkit will be released officially this fall on October 5th, so please do watch out for it. So in addition to the multiple implementation resources embedded within the guidelines, such as the many appendices that Kathleen and Jennifer have highlighted and also made commentary on the practice notes, I did want to mention that within the guideline, you can also find the evaluation and monitoring chart. And this chart includes indicators to help you measure the implementation of this guideline and its recommendations. So you'll find both process indicators and outcome indicators. And process indicators are aligned with guideline recommendations and support process improvement, as well as the evaluation of practice change during implementation, while outcome indicators assess the impact of implementing evidence-based practice changes. So as you can see, we not only want you to read the guideline, but we also provide many opportunities for you to implement this guideline within your practice, as well as see the changes that this guideline can have within your setting. So that brings us to our conclusion of the webinar today. Thank you so much for your participation and the excellent questions. If you have any other questions pertaining to this guideline, please feel free to contact us at the contact information posted on this slide. I did want to mention that funding for this guideline was provided by the Government of Ontario, and we are very grateful for that. Thank you everyone for joining, and we again really encourage you to download the guideline if you haven't, and please be in touch with any questions you have, and have a great, wonderful rest of the day.
Thank you.
Thanks, Napson. I just wanted to also note that the recording of this webinar will also be posted on the same BPG webpage, and I've just put the link in the chat also.
Great.
Thank you.